How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, they're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA. We're all made of the same.
Hello, you're listening to DNA Today, a genetics podcast and radio show. I'm your host, Kira Deneen. DNA Today informs you on what's happening in the genetic world. During this broadcast, I'm educating you, the public, on genetic and health topics through event coverage, news stories, book movie reviews, and interviews. Guests include genetic counselors, like today's episode, researchers, patient advocates, and professors in the field of genetics. Today, I'm joined by Megan Maxwell. Megan's a genetic counselor with experience in clinical, laboratory, sales, educational, and research settings. She's currently a genetic counselor project manager for the MilSeq Project at Lackland Air Force Base in San Antonio, Texas. This research is conducted under the Genomes2People research program at Brigham and Women's Hospital, Harvard Medical School, which is focused on the medical, behavioral, and economic implications of translational genomics and personalized genomic medicine in the Air Force Personalized Medicine Program. Megan earned her BS in human biology from University of California, San Diego, and her MS in genetic counseling from California State University, Northridge. Thanks so much for coming on the program and talking to us about this really cool project.
Oh, of course. I'm super excited to talk about genetic counselors' research roles and to talk about the MilSeq Project with you today.
Yeah, we're really getting into really what you do and not necessarily kind of a more generic interview about the field and everything. So we're kind of getting best of both worlds today. Let's start out with what genetic counseling actually is. What does a genetic counselor do?
So, my opinion is that what a genetic counselor does depends really largely on his or her work setting. So, for example, when I worked as a prenatal genetic counselor, my main focus in that position was to inform and educate women and couples about the risks and benefits of genetic testing either on themselves or on the pregnancy or both, given a particular indication. Versus when I worked as an inherited cancer sales rep, I informed and educated healthcare providers on the advantages of utilizing gene panels for assessing hereditary cancer syndrome risk for certain patients over the traditional single gene testing, which sounds a little weird now because it's so commonplace to use cancer gene panels. But back then they were pretty new and people were hesitant about using them. When I worked as a lab genetic counselor, part of my role was still informing and educating, mostly healthcare providers on the appropriateness of genetic testing and result interpretation. But a much larger part of my role was managing prenatal genetic testing on irreplaceable specimens. So because in large reference labs, it's important to ensure that there's kind of specialized oversight for prenatal genetic testing. The great majority of their specimen processing is usually blood, urine, things like that. And the majority of their test menu is non-genetic, like CBCs, hemoglobin A1C, so on and so forth. So
more protein-based on that sense.
Yes. So they typically don't come across irreplaceable specimens or genetic testing nearly as often as dedicated genetic labs would. So I also had a seat on the launch team of their laboratory-developed prenatal cfDNA screening assay. So I was involved in everything from the design of the report to the language used in resulting the results to data collection and publication. And that's where I really realized that I enjoyed being involved in research. I've also taught medical genetics to master's level physician assistant students. So I guess the short answer to the question is that I think, at least, that genetic counselors do pretty much whatever they put their mind to in the field of genetics.
And you've really had experience, as you just, quickly went through, of being in so many different settings that, you were in prenatal and then you're in hereditary cancer. And so those are very clinical roles. And then you kind of started more shifting towards research and, being more in the laboratory and on that side of things. So it really, you have a really cool career that really captures so many of the different directions and areas genetic counselors can go in and specialize in. And, if people do know genetic counseling, they probably think of a genetic counselor sitting with a patient in a hospital setting and kind of explaining genetic testing. But as you said, genetic counseling really goes far beyond that.
Yeah. Yeah, absolutely. And thank you for that compliment. I take that as actually a very high compliment because, since coming into the field, I've reached kind of a middle point in my career, right? I'm not a new genetic counselor anymore, but I'm not somebody who's been in the field a very, very long time. But in my time in the career, I feel very passionately about the fact that I do think that the definition of what is a genetic counselor needs to be expanded, because I do think at this juncture that there's enough representation in each of the kind of the subspecialties that we need to be projecting more out to the public than just the clinical role, which is the traditional role that genetic counseling came from, and that will always have a place, and I think that should always be respected. But now, over 25% of the genetic counseling population is comprised of other roles. And when I was teaching my physician assistant students, for example, I was teaching them from a text, and there was a chapter that covered genetic counseling. And here I am, a laboratory genetic counselor at the time, teaching physician assistant students, so in an adjunct professor role, and I could not find a definition of genetic counseling in that chapter that described anything close to what I did. And when I went on our professional website, similarly, I could not find a definition of genetic counseling that described what I did. Now, having gone back in preparation for this interview, I do see that they've added a sentence about research genetic counselors, which makes me very happy. But there are still genetic counselors that run the genetic counseling academic programs. There's genetic counselors that work in labs. There's genetic counselors that work in sales. There's a lot of diversity now.
And there's even genetic counselors that have their own companies, and private practices are also something that are popping up. So there's really just so many different roles, as you're explaining. And I think part of the problem of these definitions and the public awareness is that the field is changing so rapidly that we're having a hard time keeping up with it.
I would agree, totally. I think that it needs to, when you study business, the most effective business models are the business models that are less rigid and they're more fluid, right? So they can respond and adapt to change quickly. And I think that that's more of the model that we need to be striving for in the genetic counseling field, because the genetic counseling field is advancing almost as quickly as genetics itself.
Which is pretty quick.
Yes, ma'am.
So talking about how you are a research genetic counselor, and that's kind of where you categorize yourself at the moment in your current position, talk to us a little bit about what the Genomes2People research program is. I believe I've talked about it on the show previously, but it's been a while, so remind my audience.
Of course. So the Genomes2People research program, which we fondly refer to as G2P, it's actually a very young research program, but it's been very impactful in the field of genetics and genomics since its inception. It was founded by Dr. Robert Green, who most people would probably be familiar with him in terms of in the genetic counseling field, in terms of that he authored the ACMG recommendations for reporting incidental findings in clinical exome and genome sequencing. Right now, we're comprised of about 20, again, like a diverse set of team members. So we have faculty postdoctoral research fellows, genetic counselor project managers, research assistants, student trainees, and the main goal is, the slogan is research in translational genomics and health outcomes. So what we really want to examine is the integration of sequencing into clinical care of patients of all age ranges, from infant to adult. Also studying the impact of direct-to-consumer genetic testing.
So that's the 23andMe and that kind of thing.
Yeah, so that would be, your standard, you're interested in your ancestry, or you're interested in your, looking at the length of your telomeres to assess your age, or, things of that nature, where you, spit in a kit and mail it off, and there's no clinical intervention, that kind of thing. And then I would say that probably the main goal, and this could be my bias, but is studying the kind of health outcomes of genomic sequencing in healthy people. And that's mainly to accumulate data and gain novel insights into penetrance. There's this concept, this emerging concept, that maybe all of genetics up till now has been one big ascertainment bias. So why do you find Noonan syndrome mutations in people who have Noonan syndrome? Well, it's because they look like they have Noonan syndrome. So you tested them for Noonan syndrome, right? But there are individuals some of the first individuals who submitted their DNA for whole genome analysis. In one individual, a pathogenic Noonan syndrome mutation was identified, and this individual clearly did not have Noonan syndrome, right? So, have we been finding what we've been finding because we've had kind of blinders on and only testing people who have clinical symptoms? And the only way that you're ever going to gain meaningful data about penetrance and variable expressivity is if you start exploring those things in healthy individuals.
And so it really helps gather information and kind of have more perspective, as you said, of, we've maybe had blinders on of, okay, you have symptoms of this disorder. Let's test you. Hey, look, we think you have mutations that have led to the development of this disorder. But now we're kind of rethinking that.
Yes. And so that would be, like I said, I might be a little bit biased because, Genomes2People, they also do, Alzheimer's research with brain imaging and stuff like that. But, in my role in Genomes2People, I really feel like that's, my main goal in the research that I do in the direction that we're going.
And so your specific project that you're working on is called the MilSeq Project. So what exactly is this project?
So the formal title, we again affectionately call it the MilSeq Project, but the formal title is Enabling Personalized Medicine Through Exome Sequencing in the U.S. Air Force. So
a little longer.
Yeah, a little bit longer, a little bit more of a mouthful, but
it explains more.
Exactly, more descriptive of the objective, right? So the MilSeq Project is actually a collaborative research effort. So it's was actually kind of prompted by the 2015 Precision Medicine Initiative. And it came originally from the Air Force Personalized Medicine Program and the Air Force Medical Genetics Center. So the Air Force Medical Genetics Center is basically the in-house genetics laboratory for the entire armed forces. And then also with Brigham and Women's Hospital, Harvard Medical School, my employer, and then Baylor College of Medicine is also involved. And essentially in the study, 75 healthy active duty airmen are offered the opportunity to have comprehensive whole exome sequencing for monogenic conditions, meaning your standard, what you think of as Mendelian genetics, as well as pharmacogenomic information. So if we detect altered metabolism in the way that they may metabolize certain chemotherapies, analgesics, things of that nature. And then additionally, what we are calling risk alleles, like CHEK2. So, for example, if you're a carrier of mutation in CHEK2, you have, even though it's not guaranteed to have breast cancer, you have about a 2 to 4-fold increased risk over general population.
So it works in a similar way to BRCA, which listeners may be more familiar with. It's the same concept.
It's the same concept, but the risk threshold is much lower than what it would be if you had a BRCA1 or 2 mutation.
And so what exactly is whole exome sequencing? So this is something that is being performed on the samples from your participants. But what information do you get from it? What are you really looking at in a whole exome sequencing?
So whole exome sequencing is, very similar to whole genome sequencing in terms of you're looking at a lot of genetic information at one time. So historically, genetics has had to follow kind of what I would consider kind of a sad model, right? So someone in the family has had to become ill with the condition, or someone may have to have a baby, diagnosed with a condition or with a congenital birth defect or something of that nature in order to raise awareness that, hey, oh my goodness, we have this condition running in our family. And then really the only genetic testing option that you have is to test for that one condition that you've identified. So what whole exome and whole genome sequencing do is that there's about 5,000, give or take, genes known to be associated with genetic disease if there's a variant identified in one. And so it allows you to look across those, give or take 5,000 genes for disease variation in any of them, right? So no genetic test is 100% perfect at detecting every genetic condition, because some conditions, the variant mechanism is kind of very specific and difficult to detect outside of certain platforms. So it's not a comprehensive result, but it's a pretty robust result that you get back about disease variation across many, many genes. The main difference between exome sequencing and genome sequencing is that exome sequencing looks only at the sequences that ultimately code for proteins, and it doesn't look at anything in between. So the more technical terms for that would be that exome sequencing only looks at exons, and that genome sequencing looks at exons and introns as well.
And so by only looking at those exons or the active genes, you end up with a much smaller percentage of the overall genome that you're looking at.
Exactly. So it's a technology that is, less expensive to do, but you also have what some people consider to be more easily interpretable results from it, if that makes sense.
That makes sense, because you're looking at the actual genes versus kind of more of the parts of the genome that may have influences on the genes, so it kind of starts becoming more removed. Does that kind of make sense? Yes,
that's actually a very good explanation.
So by going through this project and having the participants having this information looked at, how are you actually going to be using this information? You're collecting a lot of data and a lot of information, but how can people actually benefit from kind of this preventative or proactive healthcare, as opposed to, as you were explaining before, of someone getting sick or having a disease in a family and then starting to treat and looking at the family? What are the benefits of kind of taking a couple steps back and looking at that preventive, proactive healthcare?
Yeah, so something that I neglected to mention a little bit earlier when I was talking about the study design is that we're recruiting also about 20 active duty Air Force healthcare providers as well. And they're offered the opportunity to have genomics training from me and kind of on-site genetic counseling support, where they learn to interpret and disclose the genomic finding to the participant airmen, right? So the benefits of doing something like this is that, the active duty airmen participants, they obviously have the opportunity to learn things about themselves, right? Like health risks, so that they can make informed lifestyle choices and health management decisions, and have access to reproductive options that can potentially mitigate those risks, right? So these results are being incorporated into their military medical record, and so they can actually be used in their clinical care and management, right? So we felt very strongly about, what's the point of doing all this and getting data on these individuals without, it's a shame to not return it to them, right? So that they have the benefit of this information. And so, the safety of the study was very important to us. And, we made sure, obviously, that we got, IRB approval and human subjects right research. So, research, accreditation and things of that nature. So the participants are very well protected in the process. But we definitely wanted to make sure that they had the benefit of the information. The healthcare providers, obviously, they have the opportunity to advance their knowledge of genomic technologies during a time when the field is accelerating towards, as you said, kind of a new proactive healthcare model rather than the existing kind of reactive sick care model. So, the Air Force providers have an advantage to kind of do almost continuing education as a part of this process. And then the Air Force, has the opportunity to better understand how to practically integrate genomic sequencing into the military health system, as well as clinical utility, which is, very important. And then the impact on downstream healthcare utilization as well.
And part of your role in this as the genetic counselor project manager, you kind of touched upon in saying that with participants, you're kind of explaining this results to them. You're translating the genetic information into layman's terms so that the participants can understand, and you're educating the healthcare providers so that they're kind of, as you said, continuing education, which is a great thing. Are there other roles that are kind of part of being this project manager?
So, the better question might be like, kind of what don't roles or what roles don't I have?
Would that be the quicker answer?
Yeah. I mean, this is a very small pilot project, right? So I'm kind of a little bit of a one-woman show. I wear a lot of hats on the Air Force Base. So, and actually most of which, and this kind of relates back to our original discussion, most of the things that I do apply my genetic counseling skill set in non-standard ways, right? So I think the most obvious thing is that I'm responsible for the day-to-day administration and coordination of the study. So, I mean, that can be anything from leading team conference calls to amendments to the protocol to progress reports back to the Air Force. I'm also responsible for the recruitment of both the active duty airman, patient, and provider participants. I perform all the consent sessions because, again, we really want to maximize the safety of the research protocol. So having a genetic counselor consenting these active duty airmen to the research study, the goal of that was to make sure that they were really very thoroughly consented. I take their pedigrees. As you said, I provide the healthcare provider genomics education. I administer the study surveys. I use my genetics expertise in kind of the traditional way to monitor the safety of the result disclosure sessions between the patient participants and the provider participants. And I facilitate, study logistics in general, such as, the blood shipment and things like that. And I also write up the research abstracts and hopefully publications. Some publications once more data are available.
So speaking of publications, what's the status of this project? What has that publications kind of included in terms of new information and research?
So we're currently in the recruitment phase for both the patient and provider participants. So we don't have what I would call outcome data yet. So the majority of what has been presented has been kind of data that has been ascertained through the development of the protocol. So, for example, I presented an introductory abstract under the LC category at the last American Society of Human Genetics meeting in October in Orlando. Which kind of described the overall study design, but it also discussed the special considerations of genomic sequencing research in the military. Because, as a team, we had to learn about doing genetic research in the military in order to make this, a practical and safe protocol, right, to be performed. And so there are certain things that you have to consider when doing that in the military setting. So we had to learn all of those things. And so that was, our point in that was kind of expressing that even though there are data available in the civilian population on genomic sequencing research, because the military is such a different environment, you kind of can't, those are not equitable, right? So you can't compare outcomes from the civilian population to what the outcomes would be in the civilian population. And then also we have submitted a abstract for consideration to the American College of Medical Genetics and Genomics meeting in April.
Nice. So very exciting that you're getting out there and speaking about it on this show, but also a lot of other venues and getting this information to the public. Another question I had was kind of about the participants, of what protections you have against genetic discrimination, if any really exist for service members in the military.
Yeah, so one thing that some people in the genetics community know is that GINA, the Genetic Information Non-Discrimination Act, is for civilian protections, right? So although that does apply to military service members once they separate from the military and become civilian, right, it does not apply to them when they're in the military. So that's a really common question, is kind of what protections do they have? And there are actually very robust protections against genetic discrimination in the entire armed forces, but there are also some that are specific to the Air Force, which is the branch that we're working with and collaborating with in this study. So there's the National Defense Authorization Act, and then also the Department of Defense Instruction 1332. So those establish eligibility for benefits if the condition was not identified in enlistment, or if the condition was identified in enlistment, but the symptoms can be demonstrated to be service aggravated. So in other words, something about service has aggravated the symptoms beyond what you would expect for like a normal, natural progression of the condition. For that reason, a lot of the participants, in my experience so far, do not consider informing their genetic status as a disadvantage per se, because of the fact that, a congenital or hereditary condition, as long as it wasn't identified in enlistment, they're still eligible for their benefits. There's also, talking specifically about the Air Force, there's Air Force Instruction 36-2706, which it prohibits unlawful discrimination based on genetic information. So that basically means that fitness for duty can't be really evaluated, or I guess I should say, a fitness evaluation can't be initiated based on a genetic test result alone. So there has to be associated symptoms, and then those symptoms have to then be duty disruptive in order for a medical board to make recommendations that, the focus is really to ensure individual unit and mission safety overall.
So you really have a lot of protections for that go kind of beyond what GINA covers for participants that are in the military.
I think that the argument could be made that there is a bit of an extension, because GINA does not cover disability insurance, right, in the civilian population, but the military, part of their benefits, is disability insurance, right? So they'll have that through the VA. And so these protections actually do cover their essentially their military version of disability insurance through the VA.
Very cool. Well, thank you so much for coming on the show and really explaining all this of being a research genetic counselor, but talking about really what you're researching. Very cool to hear about the Genomes2People research program and your particular project with MilSeq Project.
Yeah, awesome. Like I said, I'm very happy to have been given this venue to, like I said, talk about kind of the expansion of the role of genetic counselors. And it honestly makes me excited that people like you are excited about it.
Oh, I'm such a nerd with this. I get giddy.
Hey, I'm a nerd too. Being a nerd is fine.
I think that's part of being a genetic counselor, right? That's one of the requirements.
Oh, yeah. No, it's requisite. You have to be. It's like joining, a fraternity. So...
Well, if you guys are interested in what Megan is doing and wanting to follow more, you can follow her on Twitter at Megan D. Maxwell. And if you're interested in learning more about genetic counselors, you can go to aboutgeneticcounselors.com. And on there is also a link to findageneticcounselor.com, where you can look up genetic counselors in your local area to, reach out to as a student, or if you're looking to reach out to them for medical services. If you want to learn more about the show, you can go to dnapodcast.com. I got all the episodes there. I'm on Twitter at DNA Podcast and Instagram at DNA Radio. All questions can be sent to info@dnapodcast.com. So if you have questions for Megan, you can send them there, and I will forward them on to her. Thanks for listening, guys, and join me next week to learn and discover new advances in the world of genetics.
The genes of you and me, the genes of you and me, they're all made of DNA. We're all made of the same chemical DNA. We're all made of